D2 को बुलाना। So the meeting is live now. Namaskar. I welcome all of you to this 44th episode of Searchlight. This time, the Searchlight is on updates on autoimmune disorders and pregnancy. We have faculty from Ahmedabad, Bhimavaram, Himatnagar, Jalandhar, Patan, Raipur, Vadodara, and Yamuna Nagar. We will be having two lectures. One lecture would be on managing the pregnancy with autoimmune disease, and the second lecture would be on managing autoimmune disease during pregnancy. Then we will have a panel that will just recapitulate everything. So my convener, I don't think she's been able to join. She hasn't been able to join yet. Dr. Sujayasri Sangita is the convener. She is the secretary of Bhimavaram Society. I'm the program director, and this program is Courtesy Cancer Prevention and Relief Society. So, I request everyone to join hands in prayer before we start the program proper. Now, I would like to introduce the chief guest of the evening, Dr. Parag Binewale, sir. He is one person who needs absolutely no introduction. He's the one who brought ICOG into every home in Foxy and into every society in Foxy. Thank you, sir, for being that support in our ICOG journey. He is also the ICOG chairperson elect. He's a senior consultant, obstetrician and gynecologist at Pune, PG teacher and unit head at Kamla Nehru Hospital, President Menopause Society Pune in the year 18 to 22, President Pune Obstetric Gynec Society 22-23, National Website Editor Foxy 2011 to 17, Peer Reviewer of Jogi, Chairman Young Talent Promotion Committee Foxy 2008 to 10, co-editor of the book Gynecological Manual on Adolescent Girl and Young Woman 2019, Exploring New Horizons of Obstetrics and Gynecology. He has contributed articles to books and journals, delivered orations, guest lectures in over 160 Foxy societies, and also the recipient of Best Paper Prize in AICOG and AMOGS. Welcome, sir. We are really happy that you have been able to make the time to join us. Welcome.
Thank you, Dr. Asha. I bring greetings from Pune, and it's indeed a pleasure to be sitting here in a very interesting program called Searchlight. At the outset, let me thank Dr. Asha for continuing with this activity. I remember way back in February, I received a call from Dr. Asha, and she was looking for a speaker for chronic pelvic pain, and she didn't want me to talk about endometriosis at all. So I took it up as a challenge because, whenever we talk about chronic pelvic pain, the first thing that comes in our mind is endometriosis. But she wanted me to talk about everything else except endometriosis, and I was happy that I could do justice to the presentation. So thank you for bringing a different kind of program. And even today's program is very, very interesting. I'm looking forward to listening to Dr. Rajkumar Shah, who will be talking about managing a pregnant woman with autoimmune disease. And there would be Dr. Agrawal, who will speak on how to manage the disease. So, we have both the angles covered. And of course, the panel discussion, which you're going to moderate, is going to be really interesting. Thank you for the invitation. My best wishes for the program, and please continue to carry out these activities because they are really, really important and very, very interesting. So I'm sure all the delegates will be immensely benefited by today's session. Thank you very much.
Thank you so much, Dr. Parag. You remember that I had called you for non-endometriotic pelvic pain. So with this, as usual, we have very, very short introductory programs. And now we would proceed with the program proper. We have as chairperson, Dr. Sarfaraj Kazi and Dr. Sarita Gulati. I would be introducing them in short. So Dr. Sarfaraj Kazi is the director of Navjeevan Women's Hospital, Himatnagar. He's a consultant gynecologist, endoscopy and infertility specialist since the last 20 years. He also runs a high-risk pregnancy unit since 20 years at Himatnagar. He has advanced training in gynec oncology at GCRI Ahmedabad, actually very well-rounded, fellowship in reproductive medicine and diploma in endoscopy. He's a member of Society of Fetal Medicine, organizing vice chair SOGOG 2023, president of Himatnagar Society currently and for the coming 2 years, has been local joint secretary SOGOG, state coordinator Sexual Health and STI Committee Foxy, and North Zone coordinator of Gujarat State Chapter. He has recently, in the ICOG conference, received the FICOG. Congratulations, Dr. Sarfaraj. And we have Dr. Sarita Gulati. She is an MBBS from Medical College Rohtak, DGO as well from Rohtak, DCH DMC Ludhiana, life member of Foxy and ISAR, past president Foxy Yamuna Nagar, worked as SMO and in charge gynec and obstetric at Civil Hospital Yamuna Nagar, presently working at Gulati Hospital Yamuna Nagar, and her fields of interest are infertility and obstetrics. She's conducted many camps on adolescent health and cervical cancer. Welcome, respected chairpersons, and over to you to introduce our respected speaker, Dr. Rajkumar Shah, sir. Sarita ma'am, if you would please go ahead.
Good evening, everyone. First of all, I thank you, ma'am, for making me a part of this webinar. Dr. Rajkumar Shah. I invite him to deliver this lecture. He is a senior consultant gynecologist in Nanavati Max Super Specialty Hospital, Mumbai, and medical director, Eva Medicare Private Limited, Mumbai, Thane. He is president of AFG, examiner, ICOG, RM course, visiting fellow, gynecological endoscopy, reproductive endocrinology, and infertility, Grant Hospital of Chicago, Phoenix Baptist Memorial Hospital, Phoenix, formerly lecturer OB-GYN at Wardha Hospital, R.N. Cooper Hospital, LTM Medical College and Hospital, Mumbai. He is a DNB PG teacher. Special interests are in gynecological endoscopy, infertility, recurrent pregnancy loss, and emergency obstetrics. I welcome you, sir. He'll be delivering lecture on pregnancy in autoimmune disorders. Kindly proceed.
So good evening, everybody. I bring you greetings from Mumbai and the Association of Fellow Gynecologists Mumbai. And this program seems to be gathering quite a lot of interest. I've been seeing it on the media as such. And the kind of discussion that probably you'll be generating probably will make things much, much more clearer for the people who are attending this job. So further, without any further ado, I will start with the talk because this is a long talk and it has different segments in it. So I'll just start sharing the screen. Is my screen visible?
Yes, sir.
Yes, sir.
So my topic that has been allotted to me is management of pregnancy in autoimmune and inflammatory disorders. So if we have to enumerate autoimmune disorders during pregnancy, then a few words about it will suggest that autoimmune disorders are more common in women, particularly pregnant women. Abnormal antibodies are produced in the autoimmune disorders, and these could cross over from the placenta, affecting the fetus. Pregnancy affects various autoimmune disorders in different ways. And the various autoimmune disorders that we see during the course of pregnancy are the SLE, that is the systemic lupus erythematosus, the antiphospholipid antibody syndrome, the immune thrombocytic cytopenic purpura, rheumatoid arthritis, and myasthenia gravis, which are some of the most important ones. So this is what I've enumerated in my slide here. And let's now start with systemic lupus erythematosus. So systemic lupus erythematosus in pregnancy, there is an increased SLE disease activity expected during pregnancy. This is mainly because there is increased levels of estrogens, prolactin, and the T helper 2 cytokines. There are something called as exacerbations of the disease, and the incidence of exacerbations during pregnancy and postpartum period, especially in women who have been in remission before the pregnancy, has been very progressively diminishing over the past few decades. And the possible causes of flares. Flares is something where it happens during the course of pregnancy. Suddenly there's a flare-up of SLE. So why does this happen? This happens basically because of decreased level of anti-inflammatory steroids. And this happens mainly in the postpartum period. Why? Because most of the steroids are now going out of the system, and therefore there are decreased levels of these steroids, elevated levels of prolactin because the woman is nursing the baby, and because of prolactin levels are high, and prolactin is known to be a pro-inflammatory hormone. Then there are changes in the neuroendocrine axis and the changes in the estrogen and progesterone levels. The prevalence of SLE in pregnancy is between 15 to 50 per 1 lakh population. And in the US, it is 1.8 to 7.6 per 100,000 person years. Now, exacerbations of lupus occurs in 20 to 30% of women with SLE. And these exacerbations, if you see, are much more or less. This is just between up to 33% in women who have been in remission for the previous 6 months. So before the pregnancy, if the woman has been in remission for 6 months, then the chances of exacerbations of this disease is much lower as compared to women who have active disease at the time of conception. And what are the exacerbations that are seen? Now, most common is the kidney disease flare. It could also cause serositis with pleural effusion or pericardial effusion. What are the ages at which exacerbations are seen? They are seen in younger patients during pregnancy, and most of the times they are seen in African, Caribbean, and Hispanics. SLE disease activity will be reviewed now, and complications related to pregnancy and adverse effects to various medications will be discussed. Now, most of the times in the first trimester, there is morning sickness, and because of the morning sickness, there are certain important medications which are taken, which do not get absorbed because of the vomiting. So therefore, constitutional symptoms like fatigue during pregnancy could surface. And if there is a disease flare, then how does it happen? Now, pregnancy does not cause a flare of SLB by itself. There are other precipitating causes. These disease flares occur during the first or second trimester or during the first few months after the delivery. And there is increased morbidity and mortality with kidney disease and occurs due to flares in the pregnancy. Now, how does this present? Look, for example, kidney disease. The women with organ damage at the time of pregnancy may have difficulty, and more so with a disease in the kidneys. Pregnancy with lupus nephritis, mark you, with lupus nephritis is associated with an increased risk of fetal loss to the tune of 75%. And this could cause worsening of renal and extrarenal manifestations. And there are several renal exacerbations that are possible. Therefore, women with lupus nephritis are encouraged to delay pregnancy till disease is rendered inactive for 6 months. So they are supposed to conceive after the disease has been silent for 6 months. Adverse effects on the fetus due to steroids or other immunosuppressive drugs which are administered can be minimized if pregnancy occurs. Women are off these drugs. So when they are in remission, when they are off the drugs, it's best time to conceive. However, continuing steroids and azathioprine, which is the immunosuppressant, is preferred in certain patients depending on the rheumatologist who's managing. Now, usually this is associated with preeclampsia. Preeclampsia is a frequent complication of pregnancy, and it is difficult to distinguish between lupus nephritis and preeclampsia. It requires certain lab tests as such. Most likely patients with antiphospholipid antibodies, diabetes mellitus, or a previous history of preeclamptic toxemia, or having pre-existing thrombocytopenia are prone to develop this. EULAR. EULAR is European League Against Rheumatism. Guidelines recommend low-dose aspirin to women at risk of preeclamptic toxemia, SLE-associated APLA or primary APLA, and combination of low-dose aspirin and heparin is recommended to decrease the risk of adverse pregnancy outcomes. Thrombosis can happen during the course of this particular pregnancy, and SLE with APLA is an additional risk, especially in pregnancy and postpartum period. Women who are on warfarin are switched to therapeutic doses of heparin because warfarin has certain problems with the fetus as such, and there is something called as a warfarin syndrome which can manifest in the baby. So once pregnancy is diagnosed, patients are put off warfarin and switched on to heparin. Women with a history of fetal loss or pregnancy morbidity with APLA are treated with prophylactic doses of heparin and low-dose aspirin. SLE with APLA and no past morbidity can be just given low-dose aspirin with hydroxychloroquine. In a retrospective study, hydroxychloroquine was associated with higher live births, lower incidence of APLA morbidities, and fetal losses which are more than 10 weeks, and placenta-mediated complications are much less in HCQS-treated women. So therefore, HCQS holds a particular position or a particular role in the management of SLE and in pregnancy. Fetal loss. Now, fetal loss is more in SLE is possible in any trimester. The first trimester losses are associated usually with APLA and markers of lupus activity, that is low complement concentration or increased anti-dsDNA antibodies and renal disease. The late losses are associated with APLA and hypercoagulable states. So women with SLE but negative for APLA are screened for genetic causes of hypercoagulability. That means there are other reasons which could be factor V laden. Sorry. So which are factor V laden or prothrombin mutations and hyperhomocystinemia. So women with anti-Rho and anti-La antibodies may have detectable amounts of antibodies in breast milk, but that is not responsible for the neonatal lupus that is seen in newborn kids. A quick word on infertility. SLE is not associated with infertility, but drugs that are used, that is mycophenolate, cyclophosphamide, lead to premature ovarian failure. So therefore, if you're going to treat the patient with these drugs, then discuss egg banking prior to the therapy. European League Against Rheumatism guidelines recommend fertility preservation, means asking them to save their eggs before going on to the therapy, before alkylating agents are used in such a management. There is a limited role of GnRH agonists. GnRH agonists are used for fertility preservation to sort of decrease the vascularity and to decrease the size of the ovaries so that they are not exposed to these drugs. But there is no data available on subsequent pregnancies in patients with SLE. So therefore, this is not a very good substance to suggest about GnRH agonist. It is better to ask them to go for egg banking prior to therapy. A word on neonatal lupus, that is lupus seen in the newborn. It typically manifests as congenital heart block or lupus rash. Rarely it presents as hepatic or hematologic involvement. It is rare in SLE pregnancies, but whenever it is there, it is quite manifested in a big way as such. It is highly associated with maternal anti-Ro and anti-La antibodies, and there is a rash with anti-RNP antibodies which are present. Not all pregnancies with anti-Ro and La antibodies are associated with congenital heart blocks. What happens is these antibodies have a tendency to pass on to the fetus, and they can block the conducting system of the heart and give rise to congenital heart blocks. So therefore, giving every woman who's pregnant steroids is not the solution as such. But what is suggested is that fetal 4-chamber echocardiography should be performed from 16 to 28 weeks to detect these things. And if it is detected, then we can start with dexamethasone to avoid its further aggravation. Most babies with congenital heart block are delivered at term. But if severe hydrops presents earlier, then early cesarean section is necessary. The neonate may require pacing because of the problems with heart block, and rarely congenital heart block children develop connective tissue disorders in adolescence, but a fragment of them will definitely develop this. Now, how is the diagnosis made? The signs and symptoms of normal pregnancy are there. They have to be differentiated from exacerbations of SLE. So therefore, like in pregnancy, there is phloasma. There could be malar rush in SLE. Proteinuria could be present. Proteinuria could be present because of lupus nephritis, which is in SLE, or could be because of preeclampsia in pregnancy. Renal disease, which is showing secondary exacerbations of the lupus, could be present also because of preeclampsia. Thrombocytopenia could be present in lupus, as well as it could be present in HELLP syndrome. And arthritis of SLE could be present, but it could be confused with pleural edema or fluid accumulation in late pregnancy. So therefore, there are confusing disorders during the course of pregnancy, and there are tests required to differentiate between the two. There are laboratory tests which are done at the first visit, physical examination including blood pressure, as we do for all patients, renal function tests such as glomerular filtration rate, urine protein creatinine ratio, and urine analysis is performed. A CBC is done, and the test for anti-Ro and anti-La antibodies is done. Lupus anticoagulant and anti-cardiolipin antibodies are done to find out whether there is associated APLA. Anti-double-stranded DNA is done to find out whether there are more connective tissue disorders. And then the complement levels are checked. The complements are CH50 or C3 or C4 levels. Now, these levels will be low in SLE and will be raised in preeclampsia. And in the first 2 trimesters, what is usually done is monthly CBC is done, platelet counts are done at the end of each trimester, and then GFR, anti-cardiolipin antibodies, and complement tests are done along with anti-double-stranded DNA and every trimester. Now, how do you differentiate between lupus nephritis and preeclampsia? So proteinuria could be present in both, but in lupus nephritis, you will find a sediment of cells which contains RBCs and WBCs, whereas in preeclampsia, it will be only proteinuria. The complements could be low in complements which we discussed will be found at the lower level in lupus nephritis, but will be increased in preeclampsia. And thrombocytopenia could be present in both, but we have to find out whether there is increase in liver enzymes and others and calcium and decreased calcium excretion in preeclampsia. So these are certain hallmarks of preeclampsia which we have to find out whether they are present in lupus nephritis. That will help in dividing the two. There is a PROMISE study done where the soluble FMS-like tyrosine 1, which is now gaining momentum, it is coming up as a big way to in studies as such, and placental growth factor is measured in the early gestation, and it has a high negative predictive value because if it comes to be negative, then we are sure that this patient is not going to develop preeclampsia or SLE-like problems during the course of the pregnancy as such. If at 12 to 15 weeks, if these levels are raised, then there's a strong predictor of severe adverse outcomes. Between 16 to 19 weeks, if you do a combination, that is SFLT1 to PLGF ratio, then it is most predictive of severe pregnancy adverse pregnancy outcomes. However, if it is negative, then 97% of the times this patient is not going to develop any kind of severe disease. Add to this fetal echocardiography. Now, women who are anti-Ro, anti-LAB antibodies positive are usually associated with congenital heart blocks. There's a serial fetal echocardiography and monitoring is done. The goal is to detect congenital heart block at early stage. Once it goes to a third degree level, probably nothing more can be done. But at any time, if the heart block is found, then dexamethasone 4 milligrams per day is given to the mother, which crosses to the placenta and can prevent development of congenital heart block. Ultrasonography can be performed in the SLE to find out whether there is an increased risk for fetal growth restriction or a possibility of preterm birth. At this point of time, it is important to confirm the sonography at the first visit to find out what are the dates of the patient and whether the patient is conforming to the growth pattern or not. A kidney biopsy may be needed to differentiate preeclampsia from active lupus nephritis if differentiation is not possible clinically. Management of this condition requires a team approach, and the team would consist of rheumatologists, obstetricians who are trained in high-risk pregnancy, and a nephrologist to manage the care of pregnant women with SLE. What is most important is these women require to go through preconception counseling. It is important to counsel the patients to tell them that the possibility of teratogenicity with the drugs that are being used, adverse effects of medications for SLE, and the importance of contraception while patient is on medications like methotrexate, leflunomide, and cyclophosphamide and mycophenolate. So when these are drugs which can cause problems to the pregnancy, most of the times they should not conceive when these drugs are on. Whenever they are in remission, only then they should plan a pregnancy. And as per Euler guidelines, they should be counseled about fertility issues, which we discussed earlier. Some medications can prolong half-life of the drugs. Some medications can eliminate the drugs. So this will have to be taken up with the rheumatologist who is going to manage the patient as such. And women who have SLE plus antiphospholipid antibodies require frequent monitoring versus those with SLE. SLE, just plain SLE, does not require aggressive monitoring, but APLA, when it gets added to the SLE condition, can make the pregnancy more high risk. Then pharmacological therapy, as per Euler recommended guidelines, is that women with SLE, hydroxychloroquine should be started before conception throughout pregnancy to sort of manage the disease activity. SLE flares, which are mild, could be managed with HCQ, glucocorticoids, azathioprine, cyclosporin, and tacrolimus, used to prevent and manage the condition as such. Moderate to severe flares are managed with IV steroids, which is given in a pulse therapy. What is most important is to avoid the use of mycophenolic acid and cyclophosphamide because they can be detrimental to the pregnancy. The HCQ throughout pregnancy is associated with decreased lupus activity, no harm to the pregnancy outcomes, and we have seen earlier that it improves the management of the patient and the condition and the pregnancy. None of the medications which are used in the treatment of SLE are absolutely safe in pregnancy. Therefore, its use should be discussed with patients after careful assessment of risk and benefits. Avoid most drugs in the first trimester because it is known to be associated with malformations. Low molecular weight heparin is indicated in women with APLA and a history of obstetric complications. There are no historical features of APLA. Women with lupus anticoagulant and or high levels of anticardiolipin antibodies should receive aspirin. Some suggest use of low-dose aspirin and low-dose heparin, even in the absence of previous pregnancy complications. This will be left to the additionally rheumatologist who will be managing the patient along with you. Breastfeeding is an important aspect, and breastfeeding is possible in most women with SLE. Some medications enter the breast milk, a fraction of it could pass on to the baby. So immunosuppressive agents, long-acting NSAIDs, which can displace bilirubin, are contraindicated when the breastfeeding neonate has jaundice. Short-acting NSAIDs such as ibuprofen, antimalarials, low-dose prednisolone, warfarin, and heparin are safe, and they could be used freely during the course of pregnancy and the lactational period. Breastfeeding patients should not take azathioprine, methotrexate, cyclophosphamide, or mycophenolate. Hydroxychloroquine can be secreted in breast milk and that can displace bilirubin and can precipitate kernicterus in jaundiced infant as such. So should be avoided should be used with care. Prednisolone in a doses of 15 to 20 milligrams per day can be used safely, because they're in smaller amounts and secreted in breast milk. Women who are breastfeeding and taking prednisolone more than 20 milligrams per day should pump the breast milk and discard in the first 4 hours after taking prednisolone to minimize the drug exposure to the infant. What kind of diet and activity do we advise? Usually in SLE, there is water in a pregnancy, there is water retention, and SLE will not tolerate this kind of water retention because it gives rise to weight increase and hypertension. Administration of calcium and vitamin D supplements will prevent osteoporosis in pregnant women. Exercise program can prevent bone loss and depression. Strenuous activity of when patients have a flare-up. Women planning conception should be asked to be risk-free for because they can land up with adverse outcome if there has been pregnancy, if there's been exacerbation of the disease in the last 6 months. So it includes checking of antiphospholipid antibodies during the course or before conception, so that the chance of fetal loss is much lesser. Also, they should be checked for anti-Ro and anti-LA antibodies because of the risk of lupus as such. And women should avoid pregnancy if the lupus is active, especially in the presence of lupus nephritis, which we discussed a number of times earlier. What are the relative contraindications to pregnancy? So if the lupus has been in flare for less than 6 months, then you should avoid a pregnancy. If there has been a stroke in the last 6 months, avoid a pregnancy. If there's been pulmonary hypertension or uncontrolled hypertension, then again, there is a contraindication for pregnancy. A moderate to severe heart failure, severe valvulopathy, severe restrictive lung disease, chronic lung disease, kidney disease stage 4 and 5, and previous history of early onset, less than 28 weeks preeclampsia or a HELP syndrome, despite having given low-dose aspirin and heparin. This can happen. Advocate the use of contraception when the patient is on immunosuppressive drugs, especially mycophenolate, because it is known to be associated with fetal malformations. Cyclophosphamide should be absolutely contraindicated during pregnancy. What is the prognosis for such patients? There is no significant adverse or positive effects of pregnancy on the course of SLE. Live births to the extent of 85 to 90% are known to happen in SLE. Only the pregnancy is considered high-risk situation in SLE patients, especially if there are no flare-ups during the course of pregnancy. Currently, in women with SLE, 50% have normal outcomes. 25% deliver prematurely, but healthy babies. And there is an increased rate of emergency C-sections because of secondary flares of the condition or because of preeclampsia. Over the last 50 years, in 1955, the 5-year survival rate was around 50%. 1990, the 10-year survival rate is 90%, and the 20-year survival rate is around 70%. Nonetheless, mortality rates with SLE are definitely higher as compared to the general population. Women with SLE are more likely to experience adverse pregnancy outcomes, especially hypertensive complications, kidney disease, preterm deliveries, emergency C-sections, PPH, deep vein thrombosis, as compared to the normal population. There is also an increased incidence of fetal growth restriction and neonatal deaths, and hospital stays are usually longer. Increased fetal mortality rates are seen in women with anti-Ro and anti-LA antibodies secondary to fetal heart blocks. Children born to SLE women have increased risk of ASD, that is autism spectrum disorders, and congenital heart defects. Patients with pre-existing hypertension, proteinuria, azotemia have increased risk. SLE women with kidney transplant seem to be doing better when pregnancies are concerned. So therefore, probably there's something lying in the kidneys which could be detrimental to their pregnancy. So this brings us to the end of SLE. And we move on to the next topic, and that is antiphospholipid antibody syndrome. I do not want to discuss in details because this has been discussed a number of times in various topics, but I'll just like to touch up a few points, and we go on to this APS syndrome. The antiphospholipid antibody syndrome causes blood clots to form too easily or excessively. It can cause the following during pregnancy. It can cause miscarriage or stillbirth. It can cause high blood pressure or preeclampsia, or it can cause fetal growth restriction, premature births, and abruptio placentae. Now, antiphospholipid antibody syndrome is characterized by presence of antibodies. These are associated with losses in the pre-embryonic, that is less than 6 weeks, embryonic, that is between 6 to 9 weeks, and fetal times when there are more than 10 weeks as such. 10 to 20% of women with early losses are positive for APLA, and a high proportion of losses occur in the fetal period, that is after the 10 weeks compared to the other population. Antiphospholipid antibodies are associated with recurrent spontaneous abortions. Now, what are antiphospholipid antibodies? Are immunoglobulins which bind strongly to negatively charged membrane phospholipids. By various mechanisms of action, the net effect that we see is thrombosis and fibrin deposition in the vessels, including uteroplacental circulation. The pathogenic mechanisms in antiphospholipid antibodies. Now, if you see this, beta-2 glycoprotein is actually an anticoagulant. This is bound to the cardiolipin surfaces there on the platelet wall as such. And when antibodies to beta-2 glycoprotein are present in the circulation, they neutralize this beta-2 glycoprotein and make this site susceptible for coagulation. So therefore, coagulation takes place when these antibodies are present. Annexin 5 is also known to be an anticoagulant, and that if it is present in the circulation, then it keeps the blood flow quite normal. There is no clumping of the RBCs as such. But without annexin, the phospholipid layer is predisposed to development of coagulation. There are various coagulation mechanisms which occur, ultimately leads to fibrin formation, and then therefore it could give rise to clotting. Now, with annexin 5 and antiphospholipid antibodies, it could cause a havoc in the system and can bring about increased fibrin formation and clot formation. So that is how the antiphospholipid antibodies will act. What are the primary features of primary antiphospholipid antibody syndrome? It is characterized by recurrent fetal loss to the tune of 80%. There could be arterial or venous thrombosis, autoimmune thrombocytopenia or hemolytic anemia, early onset or severe preeclamptic toxemia or placental abruption, growth restriction, preterm deliveries, abnormal fetal heart rate tracings, cardiovascular and cerebral thrombosis, choriogravidarum, pulmonary hypertension, and chronic leg ulcers. So there has been a conference in 1998 where they decided about the classification criteria for antiphospholipid antibodies. These are called as Sapporo's criteria, where they require one clinical criteria and one lab criteria. What are the clinical criteria that are usually used? Thrombosis of one or more confirmed episodes of venous arterial small vessel disease, and the pregnancy criteria are one or more preeclampsia or placental insufficiencies occurring before 34 weeks, one or more unexplained fetal deaths of a normal child as such after 10 weeks of pregnancy, 3 or more unexplained consecutive spontaneous abortions less than 10 weeks. And the lab criteria are medium or high titers of IgG or IgM of the anti-cardiolipin antibodies and or anti-lupus anticoagulant on 2 or more occasions. It was in 1988 said it's 6 weeks apart, but now it is accepted to be around 12 weeks. When the APDT is prolonged and not correctable by mixture with normal plasma, the presence of an anticoagulant or inhibitor should be suspected. So what are the lab tests done to diagnose antiphospholipid antibodies? Lupus anticoagulant, which involves the use of dilute Russell Viper-Wiener time, kaolin clotting time, and activated partial thromboplastin time. In anti-cardiolipin antibodies, you require to check for IgG and IgM levels, and they are measured in GPLU and MPLU units. And antibodies to beta-2 glycoprotein 1, again IgG and IgM. And this is an algorithm where you could test as to whether antiphospholipid antibodies are positive. If they are positive, then they are confirmed after 12 weeks, and then the patient is labeled as antiphospholipid antibody associated losses. A few words on antiphosphatidylserine and antiphosphatidylserine. It is indicated in early recurrent pregnancy loss. There are higher titers found in recurrent pregnancy loss before 10 weeks of pregnancy as compared to the paracetamol, and is a reliable risk factor for early fetal loss and late pregnancy losses. The time to testing is during pregnancy or close to pregnancy loss. Now, treatment options available for managing antiphospholipid antibodies is low dose aspirin to 81 milligrams per day, but it's very difficult to get 81, so we could give between 75 to 150. Unfractionated heparin 5,000 units twice daily, or low molecular heparin 1 milligram per kg body weight. Warfarin or other anticoagulants, hydroxychloroquine, prednisolone 40 milligrams per day more, which is more toxic and probably should be avoided unless recommended by the rheumatologist. Immunoglobulins could be given in resistant cases like IVIG, which can be given 500 milligrams per kg per day for every 4 weeks as such. Plasma exchange could be done, or a combination of these therapies could be done, similar in all groups. There has been some work of use of ciprofloxacin in mouse where it is known to give rise to interleukin-3 expression in splenocyte. And this is known to be a placental growth hormone which repairs placental damage, but there are no human reports so far available. Low dose aspirin in the dose of 60 to 150 milligrams brings about inhibition of thromboxane synthesis without affecting prostacyclin production. It also helps stimulate production of interleukin-3, which we know is a placental growth hormone. Heparin inhibits blood coagulation, does not cross the placenta, so there's no risk to the fetus present. Low molecular weight heparin has not been studied adequately in pregnancy loss, but has been found to be as effective as heparin in other applications. And the combination seems to improve pregnancy rates, but fetal loss may occur despite treatment. And this is one of the reasons why I suggest that it should not be used blindly. Most of the times we are used to at prescribing this basically because we have no other thing to offer. So we prescribe low dose aspirin and heparin, but that does not really answer the problem. Despite the treatment with low dose aspirin and heparin, 70% of the times you can salvage a pregnancy, but 30% of the times you cannot. And these are the results of trials. If you see here, only low dose aspirin and low dose aspirin with heparin, the combination is definitely shown to be superior and gives better results. There are certain observations which should be kept in mind. The patients who have a combination of high APLA titers and the IgG isotype have a prognosis which is worse than those with the combination of low titers and IgM isotype. So women with IgG titers and say lupus anticoagulant will fare much, much worse than what it would be with IgM titers. Type of APLA, whether it is anticardiolipin or lupus anticoagulant or anti-beta-2-glycoprotein 1, does not influence the prognosis. So any one of this is positive, it has the same kind of prognosis for the pregnancy. Antiphospholipid antibodies are found apparently in healthy pregnant women to the extent of 2%. With and apparently healthy women with frequent pregnancy loss, it would find up to 20%. But in women with SLV, there could be a 30% association with APLA. And therefore, this is something which has to be worked out in SLE patients also. What are the prognostic and diagnostic markers in antiphospholipid antibody syndrome? Women who are positive for lupus anticoagulant and or anticardiolipin antibodies, when anticardiolipin antibodies are present, the rate of pregnancy loss is much, much more than with only lupus anticoagulant. Lupus anticoagulant mostly associated with second rather than the first trimester miscarriages. Anticardiolipin positive, lupus anticoagulant negative reduces the chance of live birth by 36 to 48%, which tells you about what is the severity of anticardiolipin antibodies. Detection of anticardiolipin before gestation or the increase in its titer during gestation has a bad prognostic marker for outcome of pregnancy. If only anticardiolipin antibodies are tested, then you could find up to 10 to 63% of patients who are positive for antiphospholipids, and other 37 to 90% could be missed. And this would be some of the patients where resistant antiphospholipid antibody could be present. So therefore, it is important to test all the three tests which we discussed in the diagnosis of lupus of antiphospholipid antibodies. Presence of more than one antiphospholipid is more accurate variable than only one antiphospholipid in the predicting pregnancy loss. I think this much is sufficient for antiphospholipid antibodies. We move on to the next, that is the immunothrombocytopenic purpura. Thrombocytopenia is common in mothers and newborns and usually causes increased rate of platelet destruction, basically because of the antibodies. The reference range in normal platelet count in non-pregnant women and newborns is between 150,000 to 4 lakh. However, mean platelet counts in pregnant women are generally lower, and that's what we call as gestational thrombocytopenia. So thrombocytopenia in pregnancy, the common causes are gestational thrombocytopenia, viral or bacterial infections, and preeclampsia complicated by HELLP syndrome. ITP and neonatal alloimmune thrombocytopenia, it's called as NAIT, are relatively rare, but these are neonatal outcomes are significantly impaired and subsequent pregnancies are definitely affected. ITP occurs in about 1 to 3 in 10,000 pregnancies and could be due to frequent blood and because of frequent blood testing and unmasking of asymptomatic mild thrombocytopenia in pregnancy. We keep on checking blood for so many reasons. At that point of time, if during the platelet count, we see that the counts are dropping down, that probably rings alarm bells. It can occur during any trimester or may be known prior to pregnancy. ITP in pregnancy is associated with greater risk of bleeding at platelet counts less than 20 to 30,000 per microliters. Platelet counts typically decrease during the course of normal pregnancy. And with ITP, the decrease in platelet count may require treatment in preparation for the delivery. Because the patient has to go through delivery, there's going to be bleeding as such. So therefore, we have to be prepared for a blood loss as such. Post-delivery, everything fine. The platelet count returns to previous ITP status, and the pregnancy is not shown to increase risk of worsening ITP. ITP is a rare autoimmune disease due to abnormal T cell response. The antiplatelet autoantibodies that are produced, these cause platelet phagocytosis by the macrophages in the spleen. And the autoantibodies that are generated can cross the placenta, especially the IgG ones, and can affect both the mother and newborn which are affected. Macrophages are the main antigen presenting cells during ITP. Besides peripheral platelet destruction because of the antibodies, inappropriate bone marrow production exacerbates thrombocytopenia. Neonatal autoimmune thrombocytopenia is caused by maternal immunization against fetal paternally derived platelet-specific antigens. Initially, IgM antibodies are formed, and later on IgG. These antibodies could cross the placenta, resulting in destruction of fetal platelets and neonatal thrombocytopenia. So neonatal autoimmune thrombocytopenia is a recurrence risk. Is very high. Nearly 100% of sibling carries the significant paternally derived antigen. So if one pregnancy has been affected, be sure that the next pregnancy is definitely going to be affected. The severity is more than previous affected child, and it occurs in both sexes, develops in fetal life. 25 to 50% of fetal intracranial hemorrhages are detectable on prenatal sonography prior to the onset of labor. What is the prognosis? Women with ITP do well in pregnancy. ITP is not a contraindication for pregnancy. Unusually severe or refractory cases need treatment, and they could cause treatment with immunosuppressants, and this could be causing teratogenic effects on the baby. It's best to defer a pregnancy when the disease is active. In chronic ITP, there are more adverse outcomes as compared to ITP diagnosed during the pregnancy. Fetuses or newborns with neonatal autoimmune thrombocytopenia have permanent neurological sequelae, organ damages, and death from intracranial and intra-abdominal bleed. Maternal antibodies after birth rapidly gets degraded, and thrombocytopenia could be resolved in the newborn. Maternal hemorrhage at the time of delivery, if a risk of a platelet count is less than 20,000 per microliter, is rare. In a series of 15 cases, there were no maternal deaths reported in 1,043 cases. So therefore, the worry of postpartum hemorrhage or hemorrhage arising from episiotomy or something is very, very minuscule, and that should not be deterring you from managing such patients. Neonatal autoimmune thrombocytopenia is seen in 10% affected newborns, but 20% die because of neurological sequelae. Medical management of ITP in pregnancy. ITP before pregnancy, patients are offered preconceptional counseling, obtain details about prior medications, whether a splenectomy has been done. If splenectomy has been done, then it confers some kind of a severity of the condition. Obstetric history, what was the neonatal count of the first delivery as such. Most women can safely proceed with pregnancy and usually are suggested to deliver in an institution. Medical therapy is initiated if the maternal platelets are less than 20,000 per microliter, or if surgery or delivery is to be anticipated, then the count should be at least above 50,000 per microliter. The goal of medical therapy is to bring the platelet count to at least 1 lakh per microliter. And for this, high-dose dexamethasone 40 milligrams per day for 4 days or prednisolone 1 to 2 milligrams per kg per day are both given. Both are effective, but it is seen that dexamethasone is better than prednisolone because it causes rapid rise in the platelet count. IV immunoglobulins used in women not responding to steroids. The dose is 0.4 milligrams per kg per day for 3 to 5 days. It is an expensive therapy and would definitely be given in an institution. IV anti-D has been given. It is preferred in children. The dose is 25 to 200 micrograms per kg per day. It is effective in Rh positive individuals only. It has a limited use in pregnancy, and there's a worry about transplacental passage. So therefore, preferably not used. The best response that is seen is with IV immunoglobulins, that the platelet counts rise immediately within first 1 to 3 days. With dexamethasone, the lag period is about 2 to 14 days, and so also same with prednisolone. Platelet transfusion should not be given as such because there are antibodies present. These antibodies are going to lyse the platelets, but they can be given only in emergency. For example, if a delivery is going to happen, then about 30,000 per microliter could be should be the target as such. And for C-section, about 50,000 per microliter can be transfused. ITP in pregnancy, what is surgical management? Splenectomy happens to be the hallmark for treatment in women which are refractory to medical management. 2/3 have positive response within few days. It is rarely performed in pregnancy. It's usually avoided in the first trimester because it will require anesthesia administration, and that is dangerous from the patients as well as the baby from the fetal point of view. It is difficult in the third trimester because of the growing pregnancy. So it is safer to do in the second trimester. It has been reportedly done with a cesarean section as reported by Mahi et al. In 2013. Women with splenectomies should be immunized against pneumococcus, meningococcus, and H. influenzae. And the last few slides on the remaining part, and that is the rheumatoid arthritis. Rheumatoid arthritis may develop during pregnancy or more often shortly after delivery. If rheumatoid arthritis is present before pregnancy, may temporarily subside during pregnancy and recur to earlier levels after pregnancy, because this is definitely a level thing which shows that steroids are much more helpful. The pregnancy steroids are much more helpful in bringing a remission of the condition. The fetus is not directly affected in rheumatoid arthritis. If there is a damage to the bones, hip bones or the lower lumbar spine, then a delivery may be difficult and cesarean section may be needed. If a flare-up occurs during pregnancy, it is managed with prednisolone. Occasionally may need immunosuppressants. A flare-up post-pregnancy is known to happen. It may make more difficult for women with rheumatoid arthritis to take care of themselves and their infant. And finally, a few words on myasthenia gravis. Myasthenia gravis is a cause for muscle weakness. It affects during pregnancy and between pregnancies. The effects of during pregnancy and between pregnancies is different. Pregnant women have more episodes of weakness, need higher doses of neostigmine. The side effects like abdominal pain, diarrhea, vomiting, and increasing weakness are there. If neostigmine is ineffective, it may require corticosteroids or immunosuppressants. Certain medications we are commonly used in pregnancy, for example, magnesium, can worsen muscle weakness in myasthenia gravis. And women should be advised to confide in their doctors to tell them pre-existingly that there is a condition like this and that they should be aware of the problem. During labor, women with myasthenia gravis may need help with breathing. Maybe they may require assisted ventilation. And if they are going in for a vaginal delivery, which is usually recommended, then assistance may be needed because they may not be able to bear down as such. So a forceps application may be suggested as such. Antibodies causing myasthenia can cross placenta, and approximately 1 in 5 babies born to women with myasthenia will have this affliction. This affliction will cause muscle weakness in the newborn, but this is temporary till the time the antibodies are there. As in how the maternal antibodies in the baby disappear, recovery happens as baby does not produce antibodies to this type. So baby is immune from this. Once the antibodies go, the baby will recover and things will be much better. So to recapitulate, friends, autoimmune disorders during pregnancies are fairly common. Abnormal antibodies are produced during the condition which could cross the placenta and can affect the fetus. And pregnancy affects different autoimmune disorders in different ways. Thank you very much.
Thank you so much, sir. Thanks a lot.
My pleasure.
Really comprehensive. Over to the chairpersons, Dr. Sarfaraj Kazi and Sarita ma'am, for their words.
Hello, ma'am. Good evening.
Yes, bhai.
I just came late, was stuck in an emergency, but came on time when Dr. Rajkumar sir has started this very complicated topic, but it makes us easily understandable. He covers all the aspects starting from the SLE, EPLA, RA, myasthenia gravis, and ITP. Though it requires more and more time to discuss, but he concluded in time. It was really a wonderful and informative talk, sir. We gain a lot with this talk. Thank you very much, sir.
Thank you.
Sarita ma'am, would you like to say something?
Yes, really, it is very m-
Ma'am,
excellent talk, very crisp and very short, and everything has been considered in this.
your video
All
is off. You can on your video.
Uh, Shah sir, may I ask a question? There is
Sure.
somebody in the chat box who has asked that question on YouTube.
Hmm.
What is the dose of hydroxychloroquine?
Yeah, so it basically, if the rheumatologist is treating the condition, then usually they would use a dose of 300 to 400 milligrams per day as such. But if the lowest that can be suggested is 200 milligrams per day. And especially
Okay.
patients with APLA could do better when they are on hydroxychloroquine. Of course, the rheumatologist has to definitely step in and suggest that.
Mostly what they are doing now, ma'am, I had 2 patients. They are increasing the dose after second trimester.
Dr. Alok, Dr.
Yeah,
Alok, would you like to give your opinion here? What is the dose that you are using?
sir, unmute yourself. Alok, sir.
Well, for the last several years, we were using 200 milligrams of hydroxychloroquine, that too in the night along with milk. And we have been using it not by giving a break into it after 11 months, but continuously for 2-3 years also. The thing is only this, that we never saw any side effects, and we have always been using like this. Current recommendations come at 400, but I have not tried them.
Sir, you are continuing it during breastfeeding also?
Yeah, if there is no jaundice to a newborn.
Okay.
Sarita ma'am, you wanted to say something before we go on to the next session?
yes, I was telling that it was a very crisp and short talk, and everything has been covered very well. All the diseases like SLE, myasthenia gravis, and ITP, the rheumatoid arthritis, which are very complicated at some times, but it has been very well told. Each and every aspect has been covered very nicely. Thank you.
Thank you.
Thank you, Rajkumar sir. You have spoken for 50 minutes and people say it's a short talk. So that itself tells how the audience has been held.
Thank you. Thank you.
Sir, there are some remarks or some questions in the chat box. Please answer that
Yeah,
question
sure.
after.
So now we proceed to the second session. Today we'll have to have our panel like, rapid fire, because the second lecture still remains. I would like to introduce Dr. Vishang Patel, the Secretary of Himatnagar Society, who has helped me get all panelists for this program along with Ruche ma'am. He has a special interest in advanced lap surgeries and infertility. He is All India first rank in ICOG laparoscopy course, Young Hysteroscopic Surgeon Award,
Thank you
Top
for the
Gun
kind introduction, ma'am.
Laparoscopy Award, and he has recently been awarded FICOG. So welcome, Dr. Vishang. And we have our own Ruchi Bhargav ma'am, who is behind me whenever I'm losing hope ki nahi mil raha hai, what to do. She is there to boost me that nahi hoga, we will do. And we have always managed to do it so far. So welcome, Ruchi ma'am. She is the member of Foxy SFM, SSI, NIGF, and TCO SSI. She is consultant and director, Bhargav Advanced Gynec Surgery and Cancer Center. He is the past secretary of Foxy Jalandhar, chairperson academics, Foxy Jalandhar, patron PCOS Society, and a faculty at national and international conferences. Over to you, chairpersons, to introduce Dr. Alok Agrawal. I'm sorry that this is so compact.
No problem, ma'am. Thank you very much for the kind introduction. So we move on to our second session, autoimmune disorder in pregnancy. For the session, we invite our second speaker, Dr. Alok Chandra Agrawal. Sir is a MBBS MS. Sir is a dean in AIMS Raipur. Sir is an honorary professor was IMA. Sir was a president of Indian Stem Cell Society. Sir is also an HOD in orthopedics in AIMS Raipur. Sir was an associated editor in many journals. He is a member of many committees. He is the ex-associate editor of Indian Journal of Orthopedics, ex-member of editorial board of IJO. He is the guest editor and the chairman of IMA Academy of Medical Sciences, Raipur branch. Over to you, sir. Sir has got a vast experience and sir has got so many years of experience. So we would invite sir to speak on the autoimmune disorder in pregnancy.
Okay, full screen. Slide कैसे change होगा?
Please make it full screen.
I think it is full screen.
It's not, we can see the side panel. If there is a problem, you can just go ahead. But it's not full screen right now. Now it's full screen. Dr. Alok, you may begin. We can see it full now.
Okay, so the lecture is primarily based not only for the gynecologists, but also for the orthopedic surgeons and general people. So what is autoimmune disease as we see? It is an inappropriate immune response of the body against substances and tissues normally present in the body. In other words, the immune system mistakes some part of the body as a pathogen and attacks its own cells. The treatment of autoimmune disease is typically with immunosuppression medication, which decreases the immune response. So basically, we can divide these autoimmune diseases into two, which are organ-specific, like the Hashimoto's thyroiditis, or primary myxedema thyrotoxicosis, or pernicious anemia, Addison's disease, insulin-dependent diabetes mellitus, or it may be dermatomyositis, SLE, scleroderma, rheumatoid arthritis, etc., in which we are interested today. So if you go for the list of autoimmune disorders, you can see there is a huge list of more than 500 conditions. And most of these people will have a desire that I get pregnant and have a child. So we will be discussing the major illnesses which are common. So autoimmune disorders can be connective tissue disorders, collagen vascular disorders, immune complex diseases, autoimmune diseases. Generalized clinical findings will be there. Autoantibody mediated connective tissue abnormalities will be there. There will be inflammation, which is sterile. There will be rheumatic diseases with skin, joint, blood vessels, kidney getting affected, primarily in ladies. And there may be other disorders of bone, skin, cartilage, blood vessels, basement membranes, with also conditions like Marfan syndrome, osteogenesis imperfecta, and Ehlers-Danlos syndrome. Well, the pathogenesis has not been much described, but it is thought over. These are immune-mediated disorders associated with and those without autoantibody formation. RA factor may be present in rheumatoid arthritis. In others, it will not be there, as in seronegative arthritis, dermatomyositis, polymyositis, ankylosing spondylitis, etc. So immune-mediated disorders can be separated into those clearly which don't display the rheumatoid factor or which do present them, as I was already discussing. Renal involvement is common and often adversely affects pregnancy, and a search for coexisting renal involvement is paramount. Hypertension likewise is common in these patients, which gets exacerbated during pregnancy. And in some of the disease immune-mediated cases, Antiphospholipid antibodies, as discussed previously, will be there to cause injury to maternal vasculature and to the placenta. So there is an immune system which protects cells, tissues, and organs perceived as self to attack and destroy foreign non-self antigen materials by the production of antibodies. And this protection has two phases: an innate phase, where there is a broad, rapid mediated through neutrophils, and an adaptive phase, which will be with antigen-specific reactions through T and beta lymphocytes that result in memory for future exposures. For some as yet unknown reasons, the immune system may be stimulated to begin producing antibodies directed against self or normal tissues. And these misdirected antibodies are called autoantibodies. The stimulus responsible for their production is unknown, but maybe through the gut bacteria, or viral injury, or a genetically susceptible tissue. Autoantibodies induce destruction by at least two mechanisms: the cytotoxic mechanism and the immune complex mechanism. There will be major histocompatibility complex with 40 to 50 genes located on the short arm C, chromosome 6, and HLA antigens also. These genetic loci code for distinct cell surface glycoproteins, including transplantation antigens, and are involved in self and non-self recognition. Class 1 antigens include HLA-A, B, and C. Class 2 antigens include HLA-DR, DQ, and DP. Through complex interactions that include T and B cells, stimulation and interaction with immunoglobulins in the complement system, non-self antigen, when the abnormal state, self antigens in normal tissues get destroyed. Coming to immune-mediated disease and pregnancy. Well, very few immune disorders arise only during pregnancy. Maternal isoimmunization from fetal red cell or platelet antigens is the most common. Some theories of the causes of preeclampsia, eclampsia, and recurrent abortion implicate an immunological basis. The pregnancy-induced immune alterations may modulate connective tissue disorders. The predominance of T2 helper cells over the cytokine producing T1 helper cells. These immunological changes have negligible effects on immune-mediated collagen vascular disorders. The effect of large amounts of estrogen, estrogen, and prolactin must be considered. For example, estrogen upregulated and androgens downregulate T cell response, and a number of cytokines are regulated by sex. Progesterone in itself is immunosuppressive. So coming to some conditions which were already discussed, SLE in pregnancy. It has an incidence of approximately 1 in 1250 pregnancies. Over the past several decades, pregnancy outcome in women with SLE is improving. Important factors for pregnancy outcome include whether antibodies are detected, disease is active at the beginning of pregnancy, what is the age and parity, coexistence of other medical or obstetrical disorders, and whether there is antiphospholipid. During pregnancy, lupus improves in a third of women, remains unchanged in a third, and worsens in the remaining third. It is certain that lupus can be life-threatening to both the mother and her fetus. A series of complications were seen in women with thrombophilia, progestational diabetes, hypertension, renal failure, pulmonary hypertension, and the pregnancy complications like preeclampsia, preterm labor, fetal growth restriction, and eclampsia. Medical complications include anemia, thrombocytopenia, and then stroke-like conditions, pulmonary embolism and DVT, along with pneumonia and sepsis. The maternal morbidity rate at present is 325 per lakh mothers. In general, pregnancy outcome is better if lupus activity has been quiescent for at least 6 months before conception. There is no active renal involvement manifested by proteinuria or renal dysfunction. Superimposed preeclampsia does not develop, and there is no evidence of antiphospholipid antibodies. So coming to the pharmacological treatment, there is no cure and complete remissions are rare. Approximately 1/4 of the patients will be having mild disease, which is not life-threatening, but may be disabling because of pain and fatigue. There will be arthralgia, serositis, which can be managed by aspirin. The risk of premature closure of the fetal ductus arteriosus needs therapeutic doses and low doses of aspirin throughout gestation. If the disease is severe, you have to give corticosteroids such as prednisone, 1 to 2 milligram per kilogram per day. After the disease is controlled, the dose is tapered to 10 to 15 milligram each morning, and corticosteroid therapy can result in the development of gestational or even type 1 diabetes. Long-term antibody-based immunoabsorption in pregnancy for removal of antibodies and lipoproteins in women will lead to serious complications who have not responded to conventional therapy. Azathioprine is beneficial in controlling active disease. Non-pregnant patients, it is reserved for lupus nephritis or disease that is steroid resistant. Azathioprine has a good safety record during pregnancy, where the daily oral dose can be 2 to 3 milligram per kilogram of body weight. You should not choose cyclophosphamide. It is teratogenic. It is not recommended during pregnancy, and in very severe cases, it may be treated after 12 weeks. Anti-neoplastic agents and immunosuppressants, other medications to be avoided, which include methotrexate, mycophenolate, mofetil, etc. Antimalarials help control skin disease. They cross the placenta, and it has not been associated with congenital malformations. There is a long half-life, so it can be used. And severe disease supervenes, usually lupus flare, high-dose glucocorticoid therapy is to be given. Methylprednisolone, 100 milligram given intravenously over 90 minutes daily for 3 days, and then a return to maintenance dose, if possible, is the treatment. The long-term prognosis and contraception. So women with lupus and chronic vascular renal disease should limit family size because of morbidity associated with the disease, as well as increased adverse parental outcomes. Combination oral contraceptives did not increase the incidence of lupus flares. COC use be avoided in women who have nephritis, antiphospholipid antibodies, or vascular diseases. Progestin-only implants and injections also provide effective contraception with no known effects on lupus flares. Concerns that intrauterine device IUD use and immunosuppressive therapy lead to increased infection rates in these patients do not have an evidence. And tubal sterilization may be advantageous and is performed with greater safety postpartum or whenever the disease is quiescent. Coming to antiphospholipid antibody syndrome in pregnancy, it has adverse pregnancy outcomes, as already discussed. The current treatment regimens are very confusing by the clinician. The scheme discussed in diagnosis of antiphospholipid antibody syndrome is used to semi-quantify antibody levels that bind immunoglobulins G, M, and A. GPL, MPL, and APL binding units are expressed as negative, low positive, medium positive, or high positive. Low positive titers of GPL or MPL anti-cardiolipin antibodies are questionable clinical significance, and any titer of APL antibodies has no known relevance at this time. Antiphospholipid antibodies women with prior thrombotic events who have antiphospholipid antibodies are at a risk of recurrence subsequent to pregnancy. So the treatment guidelines are close antepartum observation with or without prophylactic or intermediate dose heparin and some form of postpartum anticoagulation for 4 to 6 weeks. Women with medium or high positive HA titers or those with LHC activity and a previous second or third trimester fetal death not attributed to other causes should be also treated. Similarly, immunological factors, some reported that women with recurrent early pregnancy loss and medium or high positive titers of antibody may benefit from therapy. So aspirin 60 to 80 milligram daily, which was already discussed, blocks arachidonic acid and thromboxane A2. The pathway was already discussed. And you can use unfractionated heparin subcutaneously 5,000 to 10,000 units every 12 hours. Measurement of heparin levels because clotting test may be altered by LSC to prevent venous and arterial thrombotic episodes, to prevent thrombosis and macrocirculation, and it may have a complication of bleeding, thrombocytopenia, osteopenia, and also osteoporosis. You can give immunotherapy by glucocorticoids, but should not be used with primary APS. Secondary APS seen with lupus, the dose of prednisone should be maintained at the lowest effective level to prevent flares. And they also bring about osteopenia, osteoporosis, pathological fractures, and impede wound healing with inducing gestational and over diabetes. And once both the line of therapies are failed, you go for immunoglobulins, 0.4 gram per kilogram daily for 5 days, total dose of 2 gram per kilogram, has to be repeated monthly, or is it given as a single dose of 1 gram per kilogram each month? Immunoglobulin therapy has not been well evaluated, but then azathioprine, cyclosporin do not appear to improve standard therapies, and methotrexate, cyclophosphamide, mycophenolate, mofetil are contraindicated because of teratogenic potential. And this is with all the disorders.
Sharma, Sushil Doctor.
You can use low-dose aspirin plus heparin as the most efficacious therapy, where you give low-dose heparin 7,500 to 10,000 units subcutaneously twice daily, along with the low dose of aspirin 75 mg once daily. If active lupus coexists, then prednisolone also has to be given. So what is the effect of treatment on perinatal loss? Recurrent fetal loss is still seen in 20 to 30% patients with treatment described. In their series, 23 out of 32 women with a prior fetal death had antiphospholipid antibody levels greater than 40 Ig units. With lupus antiphospholipids antibodies, you get normal pregnancy outcomes without treatment. Women with LSC and prior bad pregnancies outcome have had live wounds without treatment, and 30% of neonates demonstrate passively acquired antiphospholipid antibodies, and there is concern for any adverse effects. Coming to rheumatoid arthritis in pregnancy, you have to check and see whether the pregnancy fits in patient's plan. If it fits, yes, then you go for patient assessment, current disease activity, functional ability, quality of life, comorbidities, organ affection, outcome of previous pregnancy, and antiphospholipids. If the patient doesn't want a pregnancy, the question finishes. Now, once you have assessed a risk factor, disease activity score, HAQ, motivation scores, age, comorbidities, and seen the lab test, you agree on a preliminary target that we get this much of a remission, then we will consider whether she should get a pregnancy or not. Ideally, you should have a remission for 3 to 6 months before you go for it. Otherwise, you consider appropriate medical therapy again and bring the patient to a remission state on treatment. So these were the Euler guidelines in phase 1 and phase 2, and they are exactly how we will be describing. And these are the ACR guidelines, and they also are the same that we have been discussing, but they are available on the net, which can be followed. So when you are having pregnancy, rheumatoid arthritis may improve in up to 90% of the affected women during pregnancy. Some women will develop this condition during pregnancy, and some it will become worse. Postpartum exacerbation or having the illness is very common, and flare was more common if the women were breastfeeding. In a prospective study in the United Kingdom, and 140 women recruited during the last trimester were seen at 1 and 6 months postpartum. There was only a modest fall in objective disease activity. In 16%, there was complete remission, and at least 25% had substantial levels of disability. Although overall disease actually did not exacerbate postpartum, the mean number of inflamed joints increased significantly. So you cannot guess which lady will develop it or which will be getting better. There is a protective effect of pregnancy for women developing subsequent new onset rheumatoid arthritis. So that is good. Protective effect of pregnancy in the long term, the likelihood of new onset rheumatoid arthritis was increased sixfold during the first 3 postpartum months. Significant reduction in the risk of subsequent arthritis in women who breastfed longer than 12 months was definitely there. There was a prevalence of 0.7% who developed rheumatoid arthritis, and there was a twofold increased risk for its development in women with infants born weighing more than 4.5 kilograms. So in India, we don't have that much high birth weight, so it is good. As far as a patient having GRA in the past, which persists in adulthood, pregnancy had no effect on presentation of disease. Disease activity became quiescent or remained so during pregnancy. Postpartum flares were common in these people, and joint deformities were common in 15 to 20% people. And so you have to go for cesarean deliveries for contractile pelvis or not. There was no obvious adverse effects of rheumatoid arthritis on pregnancy outcome, including preterm labor. Women with rheumatic disease with 2 previous poor pregnancy outcomes were at high risk of recurrent adverse outcomes, and later developed the disease have had a higher than expected incidence of spontaneous abortion. So what is the management? You have to do the treatment of asymptomatic women during pregnancy with aspirin and NSAIDs, concerns for impaired hemostasis, prolonged gestation, premature closure of the electrosartoritis, low-dose corticosteroids, and gold compounds were used in 14 women out of 20 delivered healthy live wombs. Immunosuppressive therapy is not routinely used like azathioprine, cyclophosphamide, methotrexate. Only azathioprine should be considered during early pregnancy because the other agents are teratological. TNF drugs are considered category B for pregnancy in the ULR guidelines, and once the lady is pregnant, they should be stopped. Leflunomide is a paranephrin synthesis inhibitor used for rheumatoid arthritis in non-pregnant patients. It is teratological in animals and is detectable up to 2 years in plasma after discontinuation, but it has not shown teratological effects in humans. So in phase 3 patients, it may be used. Contraception combination we have already discussed. Psoriatic arthritis, the guidelines are clear. Scleroderma, the guidelines are well discussed. Back कैसे जाएंगे? So to conclude, what are the effects of pregnancy on autoimmune diseases? The symptoms of an autoimmune disease could improve, worsen, or remain unchanged when a woman becomes pregnant, depending upon a specific autoimmune disease. What are the effects of autoimmune on fetal outcome? Premature delivery in lupus and APS may happen. Fetal loss in lupus, APS, and inflammatory arthritis can happen. Fetal loss can happen, and premature delivery can happen in systemic sclerosis, and same so in vasculitis also. Patient education is important. patients with autoimmune disease should avoid pregnancy when the disease is active, especially if it is of recent onset. Pregnancy is more likely to be successful with less maternal and fetal morbidity and mortality if the mother has been in remission for over 6 months. In lupus, vasculitis, and systemic sclerosis. So this table is very important. What is recommended, what is indicated, and what is contraindicated. So you can give paracetamol throughout pregnancy. Codeine is also not contraindicated, but use it with caution because the patient can have respiratory distress and withdrawal syndromes. NSAIDs, aspirin are safe until 32 weeks of gestation, but there can be a closure of ductus arteriosus. Aspirin is indicated only in low dose steroids you should not give. And if you have to give it, keep it lower than 15 milligram in the first trimester. Chloroquine is safe throughout pregnancy. Azathioprine is a second line of treatment, but is safe throughout pregnancy. Azathioprine is not contraindicated, but is a phase 2 drug, safe throughout pregnancy. Sulfasalazine is not contraindicated and is used as a second line drug, not in the first line. Tacrolimus is also safe throughout pregnancy. But then methotrexate has to be discontinued 3 months before conception. Leflunomide you should stop and wash out before pregnancy. It takes 2 years also. Cyclophosphamide is to be discontinued 3 months before conception and pregnancy test before next infusion. Mycophenolate mofetil has to be discontinued 6 weeks before conception. Biologics, abatacept, discontinue 3 months before conception. Rituximab, discontinue 6 to 12 months before conception. Tocilizumab, discontinue 3 months before conception. Etanercept, if the patient was on it, you should discontinue a missed period after a positive pregnancy test. And satolizumab can be given throughout pregnancy with minimal passage to the fetus. Monoclonal antibodies, adalimumab, etc., are contraindicated. So basically, having pregnancy, in my experience, was a difficult job. Most of the time, the orthopedic surgeons will send these patients to a gynecologist. Most of the time, they will stick to cefuroxime, paracetamol in these patients. And as we have discussed, we take the help of our rheumatologist, Dr. Jyoti Samanta, who will be sitting with you to discuss further. But these are the guidelines. And multiple of our patients have become pregnant, have children, and they come and thank us. Because when we operate on the joints, we are supposed to write treatment also for the joints. Thank you.
Over to you, Dr. Ruche and Dr. Vishang.
Thank you very much, Dr. Alok, that you have compiled everything in such a nice way. And this last chart was really very nice because it gave us a very comprehensive view into the drugs that we can safely use and the drugs that we are supposed to discontinue before pregnancy happens. Sir, I come from a very small city of Jalandhar in Punjab, and throughout the year, I have seen myasthenia gravis, I have seen ITP, I have seen ankylosing spondylitis, I have seen rheumatoid arthritis, I have seen SLE, and of course, apple, I think all of us see. So these are no longer very uncommon, and so we need to be updated about these diseases and their treatment. Indeed, it is a multidisciplinary approach. We have to take the help of a rheumatologist. But as obstetricians, we must know how the disease is affecting pregnancy and how the pregnancy is going to affect the disease. We must have an overview of these cases. We are always scared of steroids, but we know that where an acute flares, if we need to give them, we need to counsel the patient of all the problems that can happen. But of not giving as well as giving. So we have to be aware. If only we are aware, we will be able to counsel the patient.
You are absolutely
Thank you.
right. And ankylosing spondylitis is an illness of young people,
Yes.
20 years, 22 years, 23 years. So it has to be managed. And once you get a remission, you can go for pregnancy.
Yes. Yes.
Dr. Vishang, would you like to say something? So thank you, Dr. Rajkumar sir. Thank you, Dr. Alok Agrawal, for enlightening us on a topic that usually we as gynecologists sort of shy away from. We don't read too much about it. And when the patient comes, I'm taking this treatment, we usually don't understand what's going on. So for enlightening us and showing the way forward, I thank both of you. Thank you so much. If you are able to stay along in the panel, you're welcome. Otherwise, it's really going to be a very fast, rapid fire with my experts and the panelists. So thank you. Thank you once more. Ruchi ma'am, do you want to stay or you want to leave?
I'll try to be here as long as possible.
All right. So we have our panel on autoimmune disorders and pregnancy. So we have heard all there is to hear about this from our two experts, both sides of the coin. So we will now just be having a quick recap. So Shri Ganeshaya Nama, we try to achieve excellence in whatever we do, and whatever excellence we achieve is good for us personally and for the world. Big undertakings begin in a small way. These are both my mentors from Ramkrishna Mission and Swami Anubhavananji Maharaj. So with pranams, I would like to start the panel. These are my panelists. We have Dr. Joydeep Samant, who's an assistant professor, internal medicine and consultant rheumatologist at AIMS Raipur. He has 7 years of experience. We have Dr. Sandeep Gajipura Patel. There's some mix-up. We have Dr. Patel, who's practicing in Vadodara. He's a laparoscopic surgeon. We have Dr. Sapan Doshi, President IMA Either, Secretary Himatnagar in the past, Organizing Secretary of SOGO. We have Dr. Nesargi Patel, who has a diploma in aesthetic and functional gynecology, and she really looks the part. She's practicing in Patan, Gujarat. Dr. Sandeep Gajipura Patel, he is our expert. He's practicing at Shri Hospital, Enclave and Safal IVF and Lab Center, Gotri at Vadodara. He's experienced lab surgeon, has 11 years of expertise and has an award for excellence in obstetric and gynec practice. We have Dr. Kunjan Shah. He is consultant sonography and infertility specialist, managing director, and consultant gynecologist at Krishna Women's and Multi-Speciality Hospital, New Vatva and Narol branches, Ahmedabad. Dr. Batul Wadliwala, who is the president of ISAR, Gujarat. We have Dr. Anupma Chopra, obstetrics and gynecology and fertility specialist, medical director of Chawla Embryo IVF, advanced lab and fertility unit of Chawla Nursing Home and Maternity Hospital. So we have Dr. Ritu Jain, an extremely dynamic gynecologist from Raipur. She is executive member of Raipur Gynec Society, CG ISAR, CG IAG, RMS. She was the immediate past secretary of RMS, has many, many awards, and is extremely dynamic. We have Dr. Somo Banerjee. He is from AIMS Raipur in the Department of Orthopedics. So we have one immunologist, we have one orthopedician, and we proceed with the panel. I, as usual, will not be assigning questions. So anyone is free. And at the end of each slide, we will take the opinion of the expert. So this is just a recap, so it can really be fast. What are the common autoimmune diseases of women that you see in your practice?
So,
Dr. Anupama?
yeah, good evening, ma'am. Dr. Anupama from Jalandhar. I'm in Dr. Ruche's town. So basically, we come across many patients of SLE and rheumatoid arthritis in our practice, but then we have other like Jorgen syndrome and myasthenia gravis patients, which I usually don't encounter much. My most of the practice is fertility based, and I see many patients of SLE.
What about thyroid?
Yeah,
Autoimmune
definitely.
thyroiditis?
That insulin dependent diabetes mellitus too.
Yes. Ritu, you want to add something?
Yes. Thyroid disorders are one of the most commonest we encounter. Every third patient is having some or the other level of hypothyroidism or subclinical hypothyroidism. And hyperthyroidism, yes, but very less. And along with SLE, Epla syndrome, these are the commonest which we see.
So I would request all my panelists, please put on your videos so it's easier for me to interact with you. So how does pregnancy influence the course? If somebody has an autoimmune disease, is it likely to get better or likely to get worse?
Only the rheumatoid arthritis gets better. SLE has its flares but then during the lecture, we came to know that there are patients of SLE also, which some patients have remission during the pregnancy part. But most of the SLE patients, they have flares.
Dr. Kunjan, would you like to say something here?
Mostly SLE, the chances of worsening are high in case of SLE, but rheumatoid arthritis get better in during pregnancy. It is worsened after post pregnancy, means in postpartum period, because of the certain immunological cytokines, inflammatory cytokines. The SLE worsens and rheumatoid arthritis get better.
It's basically that Th1 and Th2 helper cells predominance, the diseases which are related more to Th2, SLEs, and they are more prone to worsen or are more prone to have more flare-ups. And as was rightly discussed, diseases like rheumatoid arthritis, atopic dermatitis and all, which are more related to Th1 predominance, are going to improve during the pregnancy because of the pregnancy effect.
Because of the hormones of the pregnancy. I mean, estrogen helps.
Yes.
Yes,
So,
Dr. Kunjan?
So it's very disease specific, how the pregnancy is going to affect. So each disease has to be dealt with differently.
Because of immunosuppression during pregnancy, the rheumatoid arthritis gets better.
Yes.
Okay. So now Dr. Alok showed his last slide, which said which to use and which not to use. And I'm really sure nobody could read it.
No,
I have
first we
saved
would
it and I'm going to share it in the group. But what are the key considerations for managing biologics and other immunosuppressive therapies in pregnant women?
Basically, you have to weigh the risk versus the benefits of a particular therapy in a pregnant patient, the fetal risk and the maternal risk. So if we want to avoid that venous thromboembolism or thrombotic phenomena, then low dose aspirins and low molecular weight heparin are safe in pregnancy.
So
And
that you are talking about APLA. I'm not talking just about APLA. Dr. Jaideep, would you help us here? What are the drugs that are an absolute no-no when a woman with any autoimmune disease is pregnant?
Can you hear me?
Yes, yes.
Okay. So, if any autoimmune disease patients and pregnant, so what drugs which are strictly known are among the oral drugs are methotrexate, leflunomide, and uh,
Cyclophosphamide.
cyclophosphamide. So, regarding the cyclophosphamide, there is some point I want to mention that cyclophosphamide is usually contraindicated. However, in some patient of SLE, lupus nephritis, if it is absolutely decreed, I mean, when the disease is life-threatening, then it can be conditionally used in the third trimester. Absolutely no in the first trimester. Second trimester, very risky, but third trimester conditionally can be used to save the life of the mother after explaining the risk-benefit ratio to the family members. However, methotrexate, leflunomide, absolutely contraindicated among the drugs, oral drugs. Regarding the injectables, I already told about the cyclophosphamide, and regarding the biologicals, TNF inhibitors, which is mostly used for the rheumatoid arthritis. TNF inhibitors all can be used. Usually, they are said that there are 5 TNF inhibitors, among which 4 are available in India. So mostly they can be used till 28 to 30 weeks. However, if required, they can be used throughout the pregnancy. However, there is one important thing which should be remembered, that if the TNF inhibitor are used during pregnancy, I mean entire duration of pregnancy for the control of the disease, then in the newborn baby, the live vaccinations, among which the most important, the BCG, will be withheld till 6 months of age of the baby. And among the other biologicals like tocilizumab or rituximab, usually avoided. And the drugs which can be used during the pregnancy safely are the azathioprine, which is most common and most important drug used in the management of SLE, and sulfasalazine, most commonly used in the management of the rheumatoid arthritis, and prednisolone, depending on the dose, minimum dose should be used, minimum possible dose, and hydroxychloroquine, which should be continued.
Thank you, sir. Thank you. Dr. Varda, what is the role of placental transfer of antibodies
Good evening, ma'am.
in a patient of autoimmune disease? What is the role of placental transfer and what is the implication on the fetal health?
Good evening, ma'am. I'm Dr. Naisargi. Thank you for giving me this opportunity.
Why is your name written Varda?
Ma'am, it's my mobile name. That's why, ma'am.
Okay.
I'm Dr. Naisargi, ma'am. In autoimmune
Okay.
condition like SLE and Jagger syndromes, ma'am, so many autoantibodies like anti-RO, SSA can cross the placenta and affect the fetus. So leading complications like neonatal lupus, congenital heart block will be there. So we have to do protective management and strategy, including regular fetal heart monitoring with NST and consider for intervention to prevent neonatal complications.
Okay. So basically, antibodies are crossing over and drugs are also crossing over. Yeah. So we have to see, that risk-benefit ratio, which is the worst harm, and accordingly act. So as Dr. Rajkumar Shah sir had said that when you give hydroxychloroquine, then in the fetus you have to think about kernicterus because it blocks bilirubin metabolism. So here we have to remember that anything might cross and look for the lesser evil. Would you like to add something here? Sandeep sir? Would you like to add something? Dr. Sapan, Dr. Batul? Come back to you, Dr. Nasargi. Last line, what you are going to allow the patient to have? What is the drug you are going to allow to have?
It's hydroxychloroquine, ma'am. Hydroxychloroquine, ma'am. Because it's safe throughout the pregnancy. So we can continue that drugs and we can monitor serial-wise, ma'am.
So what is the role of multidisciplinary care? Do you think you can manage it all yourself or do you want an orthopedician, or immunologist, to pitch in?
It is a multidisciplinary approach. In all cases of autoimmune condition, there is a team, including of obstetrician, rheumatologist, as well as a pediatric also required. So both maternal as well as fetal health, we can see, we can have a test like sonography, and if a patient is on drug, then we have to adjust the therapy based on the disease activity and whether the pregnancy progression is going in better way or not.
Okay, so now
So it
this
is a
question has been
multidisciplinary.
discussed. Anybody wants to add anything in this before I go to the cases proper? So we go to the cases. So here is a case. Hydroxychloroquine use. This is the most common thing used. In our area, we have sickle cell prevalence. And in sickle cell disease, also the patients are on hydroxychloroquine, along with rheumatoid arthritis. So what is the recommended dosage?
200. 200
200 to 400.
200 to 400 milligram
Maximum of
daily.
400. Yes.
Ma'am, it is 5 milligram per kg.
Who said that?
Yeah.
5 milligram per kg?
Maximum allowed dose is 300, but
400.
the recommended dosage regimen is 5 milligram per kg, single dose regimen.
Okay, if a patient is 100 kilograms, what dose are you
Why?
going to give that patient?
Maximum
Not
400.
more than 400.
Even
Maximum
400.
safety data we have. So 400.
Maximum
Okay.
400 we can give.
What is the mechanism of action of hydroxychloroquine? How does it
Ma'am,
actually change the immune response?
ma'am, it interferes with the vacuole functioning during the lysosomal degradation. Thus, it inhibits the presentation of antigens on the cell surface. And it also inhibits the locomotion of eosinophils and neutrophils, and also inhibits the complement-dependent antigen-antibody reaction.
Okay. Okay. If you can just say a little more about it to make us understand a little, because that was, you knew it and you said it so fast, but we need it to percolate into our heads.
Ma'am, hydroxychloroquine actually inhibits the complement-dependent antigen-antibody reaction. What it does
Okay.
is, it enters the cell and interferes with the vacuole functioning during the procedure of lysosomal degradation. So what it does
Okay.
is, it inhibits the presentation of antigens on the cell surface.
Okay, so if there are no antigens on the cell surface, obviously the antibodies don't get activated.
Yes, ma'am.
Thank you. So, are there any known risks associated with hydroxychloroquine use in the first trimester?
Ma'am, it is the safest drug. Hydroxychloroquine is the safest drug, even in first trimester, second or third trimester. So it is the
Okay.
best drug to be continued throughout the gestation. There are no.
So how are you going to monitor the patient? What is the monitoring protocol? A woman is
We
on,
should
RFTs
if
and
she is
electrodes.
on hydroxychloroquine, how are you going to monitor her?
we should
Patient can
monitor
give-
regular.
Ma'am,
What
patient
are
is
you going to
monitored in two
monitor?
ways.
for
Patient is monitored.
ma'am, for hydroxychloroquine, before starting, we should get a baseline ophthalmological examination, and yearly ophthalmological examination should be done.
Yeah, it means by clinically as well as pathologically. By blood reports, we can manage it. Baseline CBC, LFT, RFT, and
Every month.
every trimester we have to assess the pathological parameter, and clinically we have to assess the lupus activity as well as ophthalmologic assessment.
There is some disturbance, I think.
I request everyone who's not speaking to keep themselves mute. When you can unmute yourself when you want to speak. Please mute yourself when you're not speaking. Thank you. So what do you suggest, Dr. Jayadi? What do you want this patient to be monitored by?
So regarding hydroxychloroquine, it is very much safe. The concern raised during the talk regarding that bilirubinemia, it is mostly a theoretical one. Practically, we never see anything like that, and we prefer our lupus patient, specifically more lupus patient to be and APLA patient, APS patient to be on hydroxychloroquine. Rheumatoid arthritis patient plus minus. However, SLE patient, it's they mandatorily be on ACQ because hydroxychloroquine it reduces the risk of lupus flare. It improves the pregnancy outcome. So
No,
overall,
what
it
I'm
benefits the
asking is very different, Dr. Jayadi.
yes.
What I'm
So the
asking is, how
monitoring
are we going to
monitoring
monitor this
yeah
patient?
monitoring there is no monitoring needed at all. The monitoring protocol is previous guideline was that at the baseline you should get a eye checkup done, and then after 5 years you can get a second eye checkup. But nowadays, it is being said if the patient didn't have any pre-existing or predisposing ophthalmological risk factor, you can get away with the baseline eye checkup and you can start hydroxychloroquine straightforward at the beginning. And the first checkup usually needed after 5 years of continuous use of hydroxychloroquine and then annually. So obviously, during the pregnancy, if we starting during pregnancy, no further checkup is needed for no monitoring is needed for ECQ unless patient complaining some specific eye complaint like this color vision, difficulty in color vision or something visual halos or like those. No extra monitoring is needed from ACQ perspective.
Okay, but I would like to differ here because I myself am allergic to hydroxychloroquine. I took it and I lost my central vision. It took me 6 weeks to recover. So, yes,
Yes,
a baseline thing has to be done. It has to be done. And if the patient is allergic, it should be withheld and
yes, if
something else
patient
needs to be
complains
given.
always, yes, if patient complain any complaint, due importance to be given always. But otherwise, no routine checkup is not necessary. I mean, during the after starting,
Yeah,
yes, baseline,
thank you.
it can be done if required. But after starting, if baseline checkup is okay, then routine checkup or routine monitoring during the pregnancy is not required. But yes, obviously, patient gives any specific complaint, due importance to be given to those.
So here now from the obstetrician point of view, I would like to say that all cases with autoimmune disorders are considered high-risk pregnancies and therefore they need high-risk monitoring. From the obstetrician point of view, they need high-risk monitoring. Ritu, would you like to dilate on that? Say something more?
Ma'am,
Yes, ma'am.
Sir has presented previously, even HCQ is in pregnancy. In second trimester, we should go for fetal echo also to rule out cardiac abnormalities. So for every patient, we are not doing fetal echo, but particular patients, we have to go for fetal echo also. So particularly HCQ
Yes.
patients, we
So
have
the
to go for
obstetric
that.
monitoring has to be done. You have to do a fetal echo. It's a high-risk pregnancy. So you're going to monitor it as it should be monitored.
Ma'am, I would like to put one more point in this because we are talking pregnancy with these autoimmune diseases. So I must say we must go with the patient hemogram and MCV, of course, and platelet dysfunctions because we are giving hydroxychloroquine plus steroids also. So we must look for the patient hemogram.
Okay. Okay. Now, can hydroxychloroquine be initiated during pregnancy if indicated, if she was not taking it previously? A simple yes or
Yes,
no.
of course. Yes, ma'am. It is indicated because it is first risk versus benefit. So we have to give. Yes, yes, it is. Yes.
When do you want to adjust the dose? Dr. Alok said that he's given it to hundreds of patients and 200 milligram is enough.
No. Yes.
When do you want to actually adjust the dose and go to that 5 milligram per kg body weight?
If we are encountering any complications like in a second trimester and third trimester, So better we, of course, it is a multidisciplinary approach. We have to take opinion of a rheumatologist also. But if it is need, then we have to increase the dose up to 400.
Okay.
Milligram per
Okay.
day.
But in
Dr.
majority cases,
Sandeep, you
madam,
want to say something? Dr. Sandeep?
No, madam.
Okay. Anybody else wants to say something before we go to the next?
ma'am, in a
Dr. Raj-
majority case, hydroxychloroquine, the dose remains mostly constant, and it is a safest drug. So there is no any evidence of if there is need of dosage adjustment. It is the
Okay.
safest. We can continue with the same dose.
Okay. Now there is a patient with autoimmune thyroid disease. Her anti-TPO antibodies are very, very high. So is there a link between these anti-TPO antibodies and miscarriage and preterm birth?
Definitely.
Yes, of course.
Definitely. These patients are at increased risk of pregnancy complications like miscarriages, early first trimester losses, and then they are at increased risk of fetal growth restrictions also. So TPO antibodies positive patients are treated as a high-risk pregnancy patient.
So if there is pregnancy, then is there any change in the treatment of Hashimoto's thyroiditis
Yes,
Yes.
or not?
You have to increase the dose if to make the
Of
patient
what?
euthyroid of the L-thyroxine if she is hypothyroid. Yeah.
Hypothyroxine, and we have to keep it into the pregnancy trimester specific ranges,
Yeah.
the TSH levels.
And if it is high,
Then
if
definitely
it is hyperthyroid, then
PTU in the first trimester is the drug of
Fine,
choice,
fine.
and we can then shift to
And
methimazole
methimazole we can add.
in second and third trimesters.
Yeah.
okay. So now this is for us
And ma'am,
obstetricians.
one more thing I want to say is कि, if TPO antibody is more, then we should consider prednisolone, like steroids to be added in therapy.
I think endocrinologists they discourage using of steroids for only TPO positive. The main aim is to make the thyroid make it
Actually, that
euthyroid, but they
arises.
don't recommend steroids for making them euthyroid.
Actually, high TPO generally are present
TPO
in
is more only then.
infertility. So for them
So
to
now
consider
this is a good panel. We have
Yeah.
two contrary views and we have a rheumatologist with us. So
Okay.
sir, what is your opinion? Do we give steroids or not?
So autoimmune thyroiditis generally it doesn't come to rheumatologist, it mostly goes to endocrinologist. But yes, as per from rheumatology point of view, we generally don't treat autoantibodies. So I don't think there is any significant role of steroid in anti-TPO just based on the anti-TPO positivity. If there is no other features of autoimmunity or no other clinical manifestations, rather than the depending on the thyroid status, treatment of the thyroid status, whether hyperthyroid or hypothyroid, that need to be seen. Just because the antibody is positive high titer, we don't treat the auto antibodies, we treat the clinical manifestations of the patients.
Yes.
These patients generally present as an infertility patient. So once we control that with steroids, these patients conceive and then we maintain them on levothyroxine.
I will be of same opinion only.
When are you going to test a pregnant patient for thyroid?
In first trimester only, when first visit patient will come, that time, or patient is having any other history also, preconceptionally when she will come, that time we have to do examination P3, P4 and TSH, ma'am.
If the thyroid levels are not tested, it's an uncontrolled thyroid disease in the mother. What are the potential fetal complications?
Neurodevelopmental.
Neurodevelopment defects, ma'am.
Right,
Growth
from the
retardation.
risk of abortions, preterms, the neurodevelopmental issues in the newborn.
Hypothyroidism.
Yes.
Cretinism.
Yeah.
So this patient whom you've kept on maybe 25 microgram or 50 microgram during pregnancy, when are you going to test her after she delivers? Are you going to follow her up in the postpartum period or you're going to forget her?
Yes, ma'am,
100%.
we have to follow every 6 weeks. We have to follow, and according to that, postpartum we have to manage her dose.
Yeah.
One thing I
Because
want to add here, ma'am, even if the
please
patient
go
is
ahead.
on thyroid, one thing I just want to add, even if the patient is on thyroid medication, once she gets pregnant while on treatment, you should test the thyroid again once the pregnancy test is positive, because immediately the thyroid requirement changes once the patient gets pregnant. So even if she is on 50, it will be somewhere 75, मतलब plus 25 हो जाता है. Usually this happens in all.
Guideline is telling like when patient is hypothyroidism pre-pregnancy and pregnancy UPT came positive, then we have to increase 25 to 30% of
Yes.
dose of what she is taking before. Otherwise, 6 milligram per kg body weight.
Okay. So now we come to the next case, the use of tumor necrosis factor inhibitors. Can you give an example of a couple of them?
Infliximab. In that all abs. Infliximab, rituximab, and all ending with abs. AB.
Okay.
We
So,
have
Adalimumab.
so they will elaborate.
So are we going to start these in pregnancy?
No.
No, we'll refer to a rheumatologist or endocrinologist, right?
Yes.
So Dr. Jaideep, you want to add something here?
So the TNF inhibitors, there are 5 TNF inhibitors as such, but in India only 4 are available: infliximab, adalimumab, etanercept, and golimumab. So the mostly indications in the disease in which it will be used in females are the most common is rheumatoid arthritis and also sometimes ankylosing spondylitis. SLE, we never use TNF inhibitors. So regarding the requirement, because TNF in rheumatoid arthritis, majority of the DMARDs cannot be used during pregnancy except sulfasalazine. So if disease is not optimally controlled with sulfasalazine, and patients desperately want to have baby, so the patient's choice is we have to respect. So in that setting, TNF inhibitor can be used, and we use often because that can control the disease, and optimally controlled disease improves the pregnancy outcome and the postpartum outcome also. So
what are the teratogenic risks?
There is not much teratogenic risk. So among all the TNF inhibitors, all of the TNF inhibitors can be used till 24 to 24 weeks of pregnancy. They can be used throughout the pregnancy if required from the disease control point of view. Not much teratogenicity encountered or reported till now in the literature. And the only thing which we need to be cautious as a clinician, that if mother used TNF inhibitor throughout the pregnancy, the live vaccination to be avoided in the baby till 6 months of age, which is very important. If they are stopped at the 24th weeks or 28th weeks, then it can be go as scheduled in the baby. And
Okay. So
that
if
is the
somebody
most
has disease control and they discontinued it at 24 weeks of pregnancy, and there is a flare up after delivery, can you start it again?
Yes, definitely we can start it again. But after pregnancy, there are many more options. Like if patient doesn't breastfeed or due to some reason, then we can straightforward go to the other DMARDs like methotrexate and leflunomide, which can be used straightforward. During pregnancy, that
Okay.
cannot be used. So
Okay. Now, if the baby who has been exposed to all this, have you found anything abnormal in those
no,
babies whose mothers got
only thing is
biologic
that there will
TNF?
be if the mother used throughout the pregnancy there will be some transplacental transfer, so baby can be immunocompromised. So that's why the live vaccination is usually avoided if mother has received it throughout the pregnancy. Otherwise, not much significant risk or monitoring needed for the baby also.
Okay. Thank you, sir. Now we have dealt with in great detail about SLE and about rheumatoid arthritis. So I'm missing that, and now I'm coming to inflammatory bowel disease. This is something we don't really pay attention to, and for the patient it is very troublesome.
Yes.
But it is sometimes overdiagnosed, sometimes it is underdiagnosed. So if somebody really has inflammatory bowel disease, how can the treatment be modified during pregnancy to prevent flare-ups?
Adjustment of dose and timing to reduce the side effect while maintaining this care, and medication which is safe during pregnancy, we should give that. So it will
So
be
what
certain
medication
biological.
are you giving for IBS?
Ma'am, pre and probiotic which is safe during pregnancy. It's so many pre and probiotic nowadays. It's there in market.
Yeah, but
So
that
if you can,
alone will not suffice. That alone is an additive, but it is not a disease-modifying drug. What are you giving in a patient who has IBS?
Yes, ma'am, we will give in ulcerative colitis, we should consider steroids and of course hydroxychloroquine also. As much the how the flare-ups of disease is there. And we must know what not to give in particularly IBD. Such like ecosprin, we must not give it in IBD because there is a bleeding tendency.
And the GI motility controllers, rifaximin and all, because they decrease the motility of the bowel, they have to be modified as per the need. Mebeverine, rifaximin, which are given to control the motility, because these patients will have diarrhea.
Yes.
Yes. And we
They
can't.
might have diarrhea and alternating constipation. So things that control bowel motility will also have to be looked after. Now, this patient suddenly gets a bleed or she gets a perforation. So if she is pregnant, are you going to operate or not?
Second trimester safe.
Yes, of course. If she perforate, then we have to
Exactly.
patient.
The mother is always more important. So if
Yes.
she bleeds, if she has a perforation, that has to be treated. But if you see varices and all, then it is easier to tackle in the second trimester. You will give probiotics. What about labor and delivery options? What is common in patients of IBD?
This perianal abscesses
perianal
and
abscess.
fissures. So better to go for an elective section because
yes.
vaginal deliveries are going to exacerbate all these problems.
Also, there is a chance of preterm labor.
Yes.
Very high chance of preterm labor.
And
what about the impact on neonatal outcome? The disease itself, will it have any impact on the neonatal outcome?
No.
Not really.
Not really. I think prematurity will be the only side effect because of preterm labor.
Yes. So if there is prematurity or there can be a loss of the fetus when first trimester mein aapko kuch operate karna pad gaya, whatever. So all that is there.
I have a question.
Otherwise, in my clinical practice, the patients of IBDs who were already diagnosed cases of IBDs and then they got pregnant, the pregnancy was uneventful. Actually,
what calcium supplements do we advise these patients?
What
calcium supplements or hematinics? Like for hematinics, we do have IV options, but for calcium, what are we going to do?
I don't think so there is any problem.
You can give calcium, there's no issue.
There is no
you
issue.
can give calcium, vitamin D. Sometimes you might have to give a little higher dosage because the absorption is not so great.
Yes.
Because
so
of
any
that,
specific calcium salt which will be more helpful here?
No.
And these
He's
most
a
of
young
these
patient.
are lactose intolerant, so they are not into dietary sources also. So anything special advice we can give them?
Now this is the last thing. Recommendation for vaccinations in infants born to mothers treated with biologics. So this has been explained multiple times.
Yes,
Live,
sir has
live
mentioned here.
otherwise, no, non-live vaccine can be given according to standard practice. Only live vaccine to be delayed.
Yes, sir just mentioned.
So now we are at the end of our session. Before I actually end, I would like one take-home point from each of you. What today you have your take-home, and then we end the session.
Can
I
I ask
start
one
with you,
question, ma'am?
Anupama.
Can I ask one question?
Go ahead.
I will
Go ahead.
be taking it as take home. If anti-nuclear antibody is positive 1 in 160, do we recommend using HCQ in these patients?
See, only anti-nuclear antibody in what?
Case of RPL.
In case of?
Recurrent pregnancy loss.
You would go with your low molecular weight heparin.
In ANA positives.
Yeah.
Not HCQs?
No.
Okay.
Not
So
HCQ.
the take home message is this only.
Okay.
Ma'am, we should ask every patient like whoever is having this autoimmune disease before planning for pregnancy, we should ask them for preconceptional counseling, and we should give some advice about preconceptional counseling about to reduce the this disease like IBD. Then we have to ask patient if we have to take history, and if they are having smoking or anything else, then we have to ask them to stop that. So because of that, disease will reduce, and low birth weight and other preterm complications will be reduced. So we have to ask all autoimmune disease patients to take preconceptional counseling, then only go for a conception.
See, for us, sometimes what happens is our patients are not diagnosed. They come to us with vague complaints. So the purpose of this panel, I think, is to sensitize anything that is abnormal, don't take it that the patient is making it up. Investigate and see, and correctly investigate. So, Dr. Kunjan?
Yes, ma'am.
One take-home point from you.
Starting from planning of pregnancy, during pregnancy, before, during and after, we have to take care the autoimmune disease in both the way, for mother also and for disease also.
Okay. Dr. Sandeep sir?
Yes, madam.
One take-home point from you.
Madam, in the first trimester, we do thyroid test for the patient that if any Hashimoto thyroiditis or any hypothyroid, hyperthyroidism, there is a chances of the misabortion and preterm labor, and so we do the thyroid test in all first trimester test.
Universal screening, yes.
Universal screening for thyroid in every patient.
Thyroid.
Yes. So, yes. Dr. Sapandoshi, Dr. Somok, Dr. Somok Banerjee?
Yes, ma'am.
One take-home point for us from you.
Ma'am, just about the recommendations for giving DMARDs and other drugs in pregnant female, we won't have to send the patients to Obgyn department to just ask for the safety profile before giving the drug.
Okay. Dr. Batul?
Yes, ma'am.
One take-home point from you.
We must. This is a multidisciplinary approach. Any autoimmune disease patient is encountered. You said is very nice take-home message. Ki history taking is must. A proper history of the patient. If a patient is having autoimmune and we are advising them for the pregnancy, then we must know what to do and what not to do.
Thank you. Ritu?
Our job doesn't end with the delivery of the baby. We have to keep that women in loop, advise appropriate tests postpartum at the end of 6 weeks, and also sensitize them the worsening of pregnancy outcomes in subsequent pregnancies. So they have to be really monitored, and they have to be, it's more about patient awareness and education, which is our part, which we should not run away from.
Okay. Thank you. Dr. Jaideep?
So the most
if you don't
all
mind,
of the
would you put on your video? We want to see you.
Madam, actually, the video is not functioning. There is some problem with the video. That's why I'm not able to have
Okay.
started. But
Okay.
in any autoimmune diseases, the planned pregnancy has a better outcome than the unplanned pregnancy, because the optimal disease control of the autoimmune disease gives the better pregnancy outcome than the uncontrolled pregnancy and setting of the uncontrolled disease. So always we should encourage the patient to have planned pregnancy in a case of autoimmune disease rather than the unplanned pregnancy.
Ruchi ma'am, as usual, I come to you last.
Ma'am, birthing is a right which cannot deny to a woman, but medical prudence suggests that pregnancy should be discouraged in patients who are having active lupus nephritis, nephrotic syndrome, or severe hypertension, because the mother comes first and the baby comes second. Sometimes you are stuck with patients who have very bad cases and they are landing up in pregnancy in spite of having counseled them. And you have to save the mother, so you have to then terminate these pregnancies. So patients who are bad cases, they have to be counseled that, well, they have to go for some other method of conception, adoption, or something rather than surrogacy.
So I think with that, we end our session. Thank you so much, starting from Parag sir, Dr. Rajkumar Shah, Dr. Alok Agrawal, Dr. Sarfaraj Kazi, Dr. Sarita Gulati, Dr. Vishang, Dr. Ruchi, Dr. Jaideep, Dr. Naisargi, Dr. Sandeep Patel, Dr. Kunjan Shah, Dr. Batul, Dr. Anupma, Dr. Ritu, Dr. Somo. Thank you. Thank you so much for sparing your evening and being with us. Thank you all delegates who have joined in and given us the urge to go on. As I said before, next week we are taking an off. And after that, we start this in a different new mode, which will be different. It will be a short 1 hour program on one topic, rapid fire with experts. So see you again in 2 weeks. Thank you. Shubh Deepavali, Dhanteras, Narak Chaudas, Bhai Dooj, Govardhan Puja. Enjoy.
Thank you so
Thank
much.
you, ma'am.
Ma'am. It's the same to you, ma'am.
Yeah, it was a wonderful seminar, ma'am. Thank you very much.
Thank you, Vishang. Thank you so much. Do you have
Thank you.
a take-home point?